let's start with the care of patients with problems of the central nervous system. The priority concepts in this chapter are going to be immunity, mobility, and then interrelated concepts we're going to talk about are pain, sensory perception, cognition, and sexuality. Let's talk about MS first. What is MS? MS is a chronic disease caused by, it can be caused either by immune problems, genetic problems, or infectious factors. But in all of those types, what happens is the nerve fibers of the brain and the spinal cord are demyelinated. So what does that mean? Myelin is responsible for it's the coating of the nerve, and it's responsible for the electrochemical transmission of nerve impulses between the brain and the spinal cord and the rest of the body. So if that myelin is gone or damaged, and sometimes there are also plaque deposits, not sometimes, but there are plaque deposits in the way, then the nerve impulses are stopped or slowed. Okay? There are several types of MS. Relapsing remitting, or RR, is where you have symptoms that develop, then they resolve. Then you'll relapse and have symptoms again. Primary progressive type is where there's no remission. There's just a steady decline in the patient. Secondary progressive means it starts off relapsing and remitting, but then eventually it gets to the point where they don't get better. They just start to decline. Progressive relapsing, this is where they'll have frequent relapse and they'll partially recover, but they never really get all the way back to where they were. All right, incidence and prevalence of med-surg. It's pretty prevalent in the United States. Ages 20 to 50 are usually affected by this. There are 400,000 noted cases in the U.S., 2.3 million people worldwide, and 100,000 in Canada. It more frequently occurs in white people of Northern European ancestry. But it can be found in people of other races and ethnicities, so you don't need to rule it out if you're seeing something that makes you think a patient has that kind of diagnosis. But it is a lot more frequent in white people of Northern European ancestry. So when you're taking a health history, you may be cued into the fact that they have MS because they're reporting vision problems, mobility problems, and sensory perception changes. So you need to make sure that you ask them what aggravates the condition. Does fatigue, stress, overexertion, temperature extremes, even maybe a hot shower or bath? Ask the family about mood changes in the patient. Do they have any kind of weird times where they're really elated for no good reason? Are they starting to develop some poor judgment and attention loss? Kind of like you guys sometimes. Attention loss. And of course, ask about a family history of MS or any other autoimmune disorders. So when we talk about physical assessment, it will often be in a young adult. They'll be complaining of weakness, fatigue, changes in vision, and sometimes the physician may think it's only exhaustion. So on page 873, let's look at the key features box of multiple sclerosis. So you're going to see in a patient with MS weakness and also spasticity of the muscles, fatigue, and they're really very sensitive to temperature changes. Okay, and here's something that's different about this disease. They have intention tremors. So what does that mean? It means that Unlike Parkinson's, with Parkinson's they had resting tremors. So when they rested, their hands shook, but when they reached to grab something or do something, their hands would steady. It's just the opposite for MS. MS does not have resting tremors, they have intention tremors. So when they reach to do something, their hand begins to tremor when they start to perform an activity. The flexor muscles often spasm. Dysmetria, this is inability to direct or limit their movement. So their arms and legs won't go in the direction that they want them to. They'll have paresthesia, numbness and tingling. Hypoalgesia, this is a decreased sensitivity to pain. Ataxia, they stumble around a lot. They have decreased motor coordination. Dysarthria, difficulty speaking due to slurred speech. I know you've probably all seen this in an MS patient before. Dysphagia, they have difficulty swallowing. So as the disease progresses, you'll notice that they drool some because they have difficulty swallowing their own spit. Double vision, nystagmus, that's where those eyes make the repetitive, uncontrolled movement. Scotomus, this is a change in peripheral vision. And they have just a decrease in vision and hearing. Tinnitus, they got ringing in those ears, and vertigo. Bowel and bladder dysfunction, they can be either flaccid or spastic. Alterations in their sexual function, like impotence if it's a man. Cognitive changes such as memory loss, impaired judgment, and decreased ability to solve problems or perform calculations. And depression, like we talked about last week, often goes along with all of these neurological problems. Okay, sorry about that. With lab assessment, like so many of these neurological diseases, there's no one single thing that we can point to definitively say, yes, they have MS. Now, cerebrospinal fluid will have an increased protein and an increased white blood cell count. Increased protein and increased white blood cell count. If you sent the cerebrospinal fluid through for electrophoresis, it'll show IgG immunoglobulins, okay? So IgG, WBCs, and protein. So what is electrophoresis, really quickly? It's where you put an electrical current through a fluid and it separates the DNA, the RNA, or the protein molecules into their own size and electrical charge. So really it's just separating things out to see what's in that cerebrospinal fluid. Okay, an MRI of the brain and the spinal cord might show plaques in at least 2 different places. Evoked potential testing can identify impaired nerve transmission along the optic nerve. So an evoked potential test, what this does is it measures how long it takes for nerves to respond to stimulation. The size of the response is also noted. Okay, so we said that if the nerves are demyelinated, that nerve impulse travels slowly or doesn't get through at all. All right, so the analysis to analyze cues and prioritize hypotheses, we have to look at the fact that the patient with MS has impaired immunity. Why do they have impaired immunity? A lot of it has to do with the kind of drugs we have to give these patients. It decreases their immunity. They also have decreased or impaired mobility. This is due to that muscle spasticity and intention tremors and fatigue, okay? So that puts them at high risk for falls, of course. Okay, decreased visual acuity and cognition And so confusion may come in here, problems with brain function. And this is due to the dysfunctional brain neurons, that myelin is gone off of them as well. Okay, so to manage impaired immunity, we have to what? Teach our patients to avoid infection. Going to teach them to avoid crowds, wear a mask, wash their hands, avoid people who are ill, and go to the doctor at the very first sign of infection. So how do we teach them to handle fatigue? They need to first evaluate factors affecting their ability to be active. Is it temperature extremes that's causing the problem? Is it inadequate food intake because they're having some swallowing issues? Insomnia? Are they not sleeping? Are they not using their meds correctly? Or is fatigue just happening at a certain time of day, so we need to kind of gear all of our activities at other times of the day? For MS patients, we definitely need to determine their need for any kind of aids. Do they need braces? Do they need walkers, wheelchairs? This can be a big safety red flag as well. So we need to make sure that we take care of all of those safety issues. Most of the time, you know, we talked about fatigue. Most of the time with these patients, we're going to schedule their ADLs in the AM so that by the afternoon, when they start to become more fatigued, they've already had those important things done for the day. We need to teach them how to set consistent rest periods between activities. We need to teach them about the likelihood that they're going to need an afternoon nap, and that's okay. PT may need to get involved. OT may need to get involved. Massages and relaxing baths can help. Teach them not to push themselves too hard. Let's see. Explore meds that help fatigue. Okay. Amantadine is a medication that helps side effects of spasticity, insomnia, paresthesia of the hands and feet. Methylprednisolone, or Ritalin, is a central nervous system stimulant, but it can cause nervousness, restlessness, and insomnia. Antidepressants may be necessary. Anticonvulsants like carbamazepine and gabapentin for neurological pain and spasms. We need to make sure, though, that we don't do everything for the patient. We need to encourage them to do their own self-care and don't rush them. That's the biggest thing. Allow the patient to have all the time they need to do whatever activity they're trying to do. Also make sure that your patient is involved in inputting, planning, and when we do plan certain activities for the patient, make sure we give them sufficient time to perform the task. Assist them with their hygiene needs, but don't do them 100%. Let them do some on their own. When they do have a flare-up and they're maybe bed-bound, make sure we're repositioning frequently. Encourage the patient to sleep prone if they tolerate it pretty well, because this helps flexor spasms. Encourage stretching and toning exercise, and of course, again, consult with PT and OT. Another thing to consider for the MS patient is incontinence. Note their reports of urinary frequency, urgency, burning, incontinence, nocturia, and size or force of urinary stream. Palpate that bladder, do a bladder scan after they void to see how much they're retaining. Try some bladder training for them. Make sure they have really good fluid intake. They need to avoid caffeine and aspartame, cranberry juice and vitamin C. Teach them to watch their urine for signs and symptoms of infection. Blood in the urine, foul odor, fever, or unexplained increase in their MS symptoms. They need to treat their pain as well. So for muscle spasticity, they may be given baclofen, okay? Or they could have a deep brain stem that could help tremors. And I think we talked about that a little bit last week. Teach them to avoid rigorous activities and increase body temp and make their home safe for them. They're at risk for slurred speech, dysarthria, and dysphagia, especially aspiration. Using a patch on one side and then the other can help double vision on their eyes, a patch on their eyes. And then on page 876, there are some complementary therapies mentioned there, like reflexology, massage, yoga, relaxation and meditation, acupuncture, and aromatherapy. All right, so planning and implementation, we've talked about that a little bit, but avoid overexertion, stress, and extremes of temperature. And that includes their body temperature as well, not just external temperatures, but we don't want them to run a fever. No hot baths, no saunas. And they also need to avoid excess chilling. Teach them about all their meds, including expected side effects and allergic reactions. Get with PT to plan exercise with periods of rest. And encourage regular social interaction. This will help with that depression that often comes with neurological issues. Occasionally, a person with MS will have a personality change. Come up with a signal to alert them that their behavior is inappropriate. Okay? This should be something just between you and them. So they may need some home care management depending on what stage of the disease they're in and which kind of MS they have. We need to educate them on their self-management as much as possible, but remember that MS often affects the whole family, and a lot of times it's unpredictable and uncertain. There are healthcare resources for them, and there is a National MS Society that we should alert them about. Okay, let's switch gears to talk about spinal cord injury. The pathophysiology for spinal cord injury, we need to take into consideration whether it's a complete severing of the spinal cord or an incomplete injury. We're also going to look at how the injury occurred. This is hyperflexion, hyperextension, axially loading or vertical compression, excessive rotation, and penetrating trauma. And we're going to look at each of those differently or separately here. So this is an example of hyperflexion, and this is a hyperflexion injury of the cervical spine. Okay, see where the hyperflexion has caused an anterior dislocation and a ruptured posterior longitudinal ligament, and those combined have caused the spine itself to impinge upon the spinal cord and injure it. Okay, so what happened is they hit something. See, in this case, a brick wall, and the head is violently hyperflexed. Okay, and this is another example of hyperflexion and hyperextension. We've looked at the hyperflexion already. Let's look at the hyperextension. This is where somebody hits you from the rear, and your head and neck are violently thrust backwards. You can get a ruptured anterior ligament and then compression of that spinal cord. Okay, the image to the right identifies axial loading. This is vertical compression, and it's a type of injury of the cervical spine and the lumbar spine. See, the first one, it shows a guy falling off a ladder and how that can disintegrate some of those bones up there and push into the spinal cord and injuring it. Look at the diving into a pool and hitting their head on a rock. That does the same thing. It causes a compression fracture, and that fracture impinges on that nerve. I'm sorry, not the nerve, on the spinal cord itself. Okay, so the etiology, what happens that you have spinal cord injury? Comes from trauma, falls, acts of violence, and sports recreation related accidents. So guess who's the most likely to have spinal cord injuries? Young males. Young males. There can be some secondary injuries to the spinal cord. Hemorrhage can cause a compression of the spinal cord. Ischemia, there's no blood flow to the spinal cord for whatever reason. It could be hypovolemia or neurogenic shock, local edema. So please note that there is decreased life expectancy even if initial trauma is survived, okay? Because once you have a spinal cord injury, you're at very high risk for things related to immobility like pneumonia and sepsis. Okay, so we talked about the young males are 80% of spinal cord injuries. Cervical cord injuries are more common than thoracic or lumbar. The average age is 43 years old. That's pretty darn young. So for prevention, we need to talk to people about avoiding taking risk, especially young males. I think we talked about this last week. Don't dive into a pool or a body of water that you don't know how deep it is or what's going on in that pool. They need to wear padding and helmets for sports. Wear their seatbelts like they're supposed to. Avoid impaired driving. Buzzed driving is drunk driving. Again, don't dive into shallow pools. Water should be at least 9 feet deep before you dive in. That's pretty deep. Okay, so how the injury occurred, the mechanism of the injury, and what kind of care they had before the hospital are all important things to note when we're trying to recognize if there has been a spinal cord injury. Your priority here is going to be your ABCs. Spinal nerves C3 through C5 run to the diaphragm. Okay, so that affects breathing. Your pulse, your blood pressure, and your peripheral perfusion are all really important things to check. The pulse strength, the capillary refill. Use the Glasgow Coma Scale, and normal is a 15. And if you're below 8, you're considered to be in a coma. Okay. Spinal shock syndrome, let's see if that's on the next slide. No, it's not, but spinal shock syndrome is the loss of muscle tone and spinal reflexes below the level of the severe spinal cord lesion. So this shock does not imply a state of circulatory collapse, but of suppressed spinal reflexes below the level of the cord of injury. This can last up to 48 hours. So it's important to note that you won't know the extent of the spinal injury for several days. So sensory perception and mobility assessment. When a person has tetraplegia or quadriplegia, paralysis of all 4 extremities, we need to be assessing them frequently. They may have deep tendon reflexes that are decreased. As far as cardio and respiratory, if the injury is above the 6th thoracic vertebrae, you may have bradycardia, hypotension, hypothermia, and this may actually lead to cardiac dysrhythmias. So we have to treat low blood pressure or the spinal cord will not be perfused. So how would we assess their breathing? Watch for breathing difficulties. If they're still breathing, it may be impaired just enough to cause atelectasis or pneumonia. Autonomic dysreflexia, this is life-threatening, okay? This is the uninhibited sympathetic discharge. Let's look at page 880. So on page 880, there's a box there that's named Key Features, Autonomic Dysreflexia. And this is going to kind of let you know what that is. What it amounts to is the sympathetic nervous system is let loose, basically. And what you have is a sudden significant rise in their systolic and diastolic blood pressure, and they become bradycardic. So their hypertension, they have hypertension and bradycardia at the same time. They'll be profusely sweating above the level of the lesion, especially in the face, the neck, and shoulders. And goosebumps are above or sometimes possibly below the level of the lesion. Their skin will be flushed looking, especially in the face and the neck. They'll have blurred vision. Spots in their visual field, nasal congestion. They'll have onset of severe throbbing headache, okay, and a really major feeling of apprehension. So we'll talk about what we do there in just a second, but the causes of it, of autonomic dysreflexia, are often caused by GI or GU problems. So the first thing you're going to check for when they start having these signs and symptoms is for a full bladder, tight clothes, constipation or hemorrhoids, if they're laying on a hard object, or temperature fluctuations. Okay, so to fix it, you just change whatever the problem is. If a lot of times it's caused by kinked catheter. Okay, so check their body first. If their bladder appears full, if they do not have a catheter in, or even if they do, you need to check position of the catheter. If they have on tight clothing, of course, remove those. Constipation, we need to prevent that. But if it happens, we may need to very quickly get that turned around. Check them. Turn them, check them for hard objects, and check their temperature. Okay, they can also develop a paralytic ileus. Okay, if they have a higher cervical and thoracic injury, they're going to have a spastic bowel and bladder. If they have a lower thoracic and lumbosacral injury, they're going to have a flaccid bowel and bladder. Pressure ulcers can be a problem because they're no longer weight-bearing. They also have problems with osteopenia and osteoporosis because, you know, it's the stopping of the feet down that is one of the things that signals the body to make your bones more dense. Okay, so they're no longer doing that, so they are suffering from osteopenia and osteoporosis. Okay, they can also have what's called heterotopic ossifications or bony overgrowths. Although that bone is still thin, it can grow into the muscle. The hip is the most common site for this, so you have to assess the hip for swelling, redness, warmth, and decreased range of motions. Okay, so that again is called heterotopic ossification. Okay, listen to their concerns, but be realistic. Offer hope and encouragement, and encourage aggressive rehab. So let's go back here. Potential for respiratory distress and failure due to aspiration, also due to decreased diaphragmatic innervation of that nerve there, or decreased mobility. All of those things have the potential in the spinal cord injury patient to cause respiratory distress or failure. They have potential for cardiovascular instability or shock, autonomic dysreflexia, like we talked about, due to a loss or interruption of sympathetic innervation or hemorrhage. They have a potential for secondary spinal cord injury due to hypoperfusion, edema, or delayed spinal column stabilization. So we have to stabilize that spinal column really quickly after we realize there's been some kind of injury. They also have decreased mobility and sensory perception due to spinal cord damage and edema. Okay, so one thing I want you to make sure you know about is that autonomic dysreflexia and what causes it and how we fix it quickly. So, taking action, of course, we need to manage their airway and improve their breathing in whatever way is necessary. Now, if we're talking in the emergency room and Lord forbid EMS brought this patient in without a C-collar on, this type of patient is not a patient you're going to hyperextend the airway in order to help them breathe, okay? So make sure that if there has been any kind of injury and a spinal cord injury is suspected or could be possible in any way, form, or fashion, make sure that they have stabilization around that neck. These patients are definitely going to need to be on a cardiac monitor because of the potential for cardiovascular instability, and their cardiac system is going to need to be assessed frequently. We need to prevent secondary spinal cord injuries by giving them steroids if we have to decrease that swelling. Do some assessments to make sure that it's not a hematoma impinging on that spinal cord, and we need to manage that decreased mobility. By the way, whenever we're doing passive range of motion for patients, whether they have a spinal cord injury or a stroke or whatever, what is that for? It's to keep their joints moving. Okay, it helps the muscles some, but it's really to keep those joints going. Okay, if a patient is on a ventilator, make sure we're doing ventilator acquired pneumonia protocols to keep them from getting pneumonia. If they're not on a ventilator, encourage the use of the IS, and you've got to assess that respiratory function a minimum of every 8 hours. On 881, it shows an example of a cough assist. Okay? Make sure that you're familiar with how to do a cough assist, what a cough assist is in a spinal cord injury patient. Okay? So we're going to have to make sure we've got home care set up, mobility skills, pressure injury prevention, ADL skills, bowel and bladder programs, a sexuality education, and prevention of that autonomic dysreflexia. Okay, all of those are very important. Okay, let's see what else I wanted to say here. So we're going to go over neurogenic shock in critical care, but low blood pressure is always one of the first things that you look for in shock. You're also going to watch that cardiac system in these spinal cord injury patients. Watch for bradycardia. Okay. Assess their color. Do their fingernails or their lips look blue? Are they becoming less conscious than they normally are? Okay. All right. So with spinal cord injury, a lot of times they will go ahead and put them on a proton pump inhibitor to help prevent those curling ulcers, which are stress ulcers. Skeletal muscle relaxers like tizanidine and intrathecal baclofen, sometimes instead of tizanidine. And just remember, with baclofen, cannot withdraw it suddenly. It can cause seizures and hallucinations. Okay. All right, what else do we want to say about this? Okay, so on page 882, there is a pink box there that will help you know what to do if a patient has autonomic dysreflexia, the immediate interventions. Okay, and this is going to be one of the only things that happens to a patient where you're going to want to really sit them up as quickly as possible, because does sitting a patient up increase their blood pressure or decrease it? It can decrease it, right? If a patient had low blood pressure, we would want to lay them down, but they have high blood pressure, so we're going to sit them up. And sometimes with autonomic dysreflexia, just doing that will help. Okay, we're going to remove or manage the cause. If it's urinary retention, we're going to unblock that catheter, check it for kinks, all that other stuff. Okay. Do they have a urinary infection or a stone contributing to the GI irritation? Do they have a fecal impaction? Okay. Examine their skin for new or worsening pressure injury symptoms. Monitor their blood pressure every 10 to 15 minutes until it's back to normal. We're going to give nifedipine or nitrate as prescribed to lower that blood pressure. Okay, so be sure and be familiar with, again, autonomic dysreflexia and the things that you should do to help that. So, what do we want to happen? What goals do we have for our patients with autonomic dysreflexia? With spinal cord injury. We don't want their neurological status to deteriorate any more than it already has. Okay? We need to ABC the patient. Always make sure that we have a patent airway, that they're breathing adequately. Okay? We're going to watch for a cardiovascular event. And if this happens, we need to make sure that we treat it quickly. We're going to make sure that they don't experience a secondary spinal cord injury, including a VTE or heterotopic ossification. Remember that heterotopic ossification is where you have, even though the bone is still thin and brittle, it grows through the muscle, and usually the hip is the most common place for that. We want to make sure that they're absolutely free from complications of decreased mobility, which would be what? Pressure injuries, right? Pneumonia, that kind of stuff. We need to help them perform mobility skills and basic ADLs, but we need to let them do it as independently as they can. Okay, and make sure that they have any kind of assistive or adaptive devices that they need to do that. All right, you have a 33-year-old man. He's brought to the ED after being hit from behind in a motor vehicle accident. The car that hit him was traveling at 20 miles per hour. He does have a cervical immobilizer on and is alert and oriented. He reports neck pain of 5 on a 0 to 10 scale and otherwise appears in no distress. What's the priority nursing assessment for this client? Is it airway, circulation, sensory perception, or level of consciousness? It is, of course, A, airway. Even if they're in no apparent distress, that airway has to be assessed first, okay? Level of consciousness, circulation, and sensory perception can be assessed after the airway. The client is admitted for observation. Upon assessment, an hour later, which finding will the nurse immediately report to the provider? Okay. Unresolved headache, a blood pressure of 90/70, neck pain remains at 5 on a 0 to 10 scale, or an increase in the Glasgow-Coma scale score. Okay. B, a low systolic blood pressure can indicate a decrease in perfusion to the spinal cord, which could worsen the client's condition. A headache may linger. I mean, they've had a massive injury. Neck pain is the chief concern, but it is unlikely to resolve completely while they're in the ED. Okay, so it's going to take a while. An increase in the Glasgow-Coma scale indicates an improvement in the client's condition. Now, if it had said a decrease in the Glasgow-Coma scale, that might be something to really look at. Okay. The next morning, the nurse notes that the client's heart rate is 48 a minute, and the blood pressure is 78/64. His skin is warm and dry. What's the appropriate nursing action? Are we going to notify the provider immediately? Apply O2 at 2 liters, raise the head of the bed to 45 degrees, or increase the rate of IV fluids from 50 to 75. Okay. So do you think it's autonomic dysreflexia? Probably not, because the blood pressure's low, not high. Okay, let's look. A, these are signs of neurogenic shock, okay? Severe bradycardia, warm and dry skin, and severe hypotension. The physician should be notified immediately because this is an emergency. It's best treated by restoring fluids to the circulating blood volume. While increasing the IV rate is a good intervention, going from 50 to 75 will not be enough, and a physician's order is needed to make this change. So giving fluids is definitely what you would want to do. However, 50 to 75 milliliters is not enough. Not enough. 10 days later, the client is scheduled for discharge to a rehab facility. What does the nurse identify as realistic initial priorities of care during rehab? We need to teach him about self-care, mobility skills, bowel and bladder training. A typical stay after a cervical spine injury like this is 1 to 2 months. Okay, not cervical spine, spinal cord injury, 1 to 2 months. Okay, in assessing a client with persistent low back pain, which question will the nurse ask as the priority? So we switch gears a little bit just to lower back pain. Are you still going to work? What helps you to manage the pain? Can you describe how the pain feels? Have you ever had an MRI of your back? Okay, so obtaining a thorough assessment of the client's pain and effective interventions to treat pain is important. The primary assessment question helps the nurse more fully understand the client's experience with pain and how the client has attempted to address the pain. All other questions can be asked as follow-up. So PQRST it, right? The nurse understands which component is a risk factor associated with the development of MS. Age greater than 50, smoking, low-carb diet, or female gender. Well, we said 20 to 50, not greater than 50 on the age. Smoking, we didn't mention that. Low-carb diet, no. So, female gender. Okay, women are affected 2 to 3 times more than men. Okay, it's suggested that this may be because of hormones. Okay, a spinal cord injury, a patient with a spinal cord injury at C5 to C6 becomes flushed and reports a sudden severe headache. Vital signs show a blood pressure of 190/100 and a heart rate of 50. What's the appropriate nursing intervention? So is this autonomic dysreflexia? Okay, what do we do first? Notify the healthcare provider, place the client in a sitting position, check the client for a fecal impaction, or check the urinary catheter for obstruction. What do we do first? Sit them up. Remember, I told you, sit them up. Of course, we're going to be looking for whether or not the catheter is kinked and if they're impacted, whatever, but they have to be, we have to sit them up first. Let's talk some more about critically ill patients with neurologic problems. Perfusion and cognition are up there on our concepts, and then interrelated concepts are going to be mobility and sensory perception. Okay, let's talk about TIAs first. They have all the signs and symptoms of a stroke, but they're transient, okay? So look at the key features on page 898. 898. At the bottom in the right-hand side, they're going to have some blurred vision, double vision, sometimes hemianopsia, which means the vision of only one eye or both is affected. Tunnel vision, okay? They're going to have some weakness, a facial droop or arm or leg drift, hand grasp. Remember the little test we did, the plantar test we did to see if, hold your arms out and see if that arm drifts in. Okay. Ataxia, their gait might be affected, their balance. They may have some numbness somewhere, vertigo, aphasia, just some temporary problems with speech, or dysarthria, slurred speech, okay, caused by muscle weakness. So how do we manage these patients? They may or may not be admitted depending on their neuro and their cardiac status. So we're going to be looking at things like atrial fib. Why would we worry about atrial fib? They can bust loose a clot to send to the brain, right? The physicians will try to find out what's causing the problem and then treat it. If it's something like atherosclerotic plaque buildup, they may have surgery to remove it. They may need some stents of some kind, antiplatelet drugs, aspirin, and clopidogrel. We may need to do something to decrease their blood pressure, control their diabetes, promote a healthy lifestyle, okay? So just remember that TIAs are temporary, they're transient. It's because of a brief interruption to cerebral blood flow. And stenosis in the carotid arteries is often pointed to as the problem. So you're going to use the ABCD assessment tool. So this is not ABCD like you're thinking, airway, breathing, so forth. This is age. Age greater than or equal to 60. That really increases stroke risk. Okay, blood pressure greater than or equal to 140/90. Either systolic or diastolic or both. And C stands for clinical TIA features. It's one-sided weakness, and of course TIAs increase your risk for stroke. D is duration of symptoms. The longer the TIA symptoms last, the greater the risk for stroke you're at. So they'll use that ABCD assessment tool and decide how to follow up from there. So what is a stroke? Okay. A stroke is the interruption of perfusion to any part of the brain, and it is a medical emergency. So what is the difference in a thrombus and an embolus? because you can have an acute ischemic stroke and you can have a hemorrhagic stroke, one or the other. And the ischemic strokes are caused by either a thrombus or an embolus. What is the difference? Most common place an embolus is formed is from atrial fib or heart valve disease. So embolus travel and thrombus form where they are, okay? So let's say you had an embolic stroke. This would be sudden development of symptoms because the clot has just floated in there and occluded everything and caused a major problem. Whereas thrombotic ischemic strokes can develop slowly because that clot develops slowly. You know, it starts out kind of decently big, may cause a few little symptoms, and as time goes by, it keeps on getting bigger and bigger and bigger until it finally occludes. So that's the difference in those two. Now, hemorrhagic, we have vessel ruptures, okay? We have intracranial hemorrhage. And what you're going to see is a spike in blood pressure ruptures a vessel in the brain tissue itself. This can be caused by a lot of different things, but cocaine is one thing. Subarachnoid hemorrhages are more common. Those are ruptured aneurysms or AV malformations. An AV malformation is just an angled collection of malformed, thin-walled, dilated vessels. Okay. So here's just some pictures. Okay. For that one at the top right, that's an AV malformation. See how they're all jumbled together there? At the bottom, it shows a hemorrhage, just a rupture of the vessel. That looks like a small aneurysm that actually is ruptured. Okay. So two types of stroke. You've got the ischemic stroke and the hemorrhagic stroke. And remember, with the ischemic stroke, it blocks the vessels with a clot, either a thrombus or an embolus, and past wherever it's blocked, there's anoxia going on, or no oxygen. Is that going to hurt? Yes, it does. Okay. Then you're also, on the right-hand side, you see a rupture of the vessel. That's your hemorrhagic stroke. All right, let's talk about the genetic risk here. First, look at whether or not a relative, a first-degree relative, has a history of hypertension, atherosclerotic disease, or aneurysm. Okay, but really and truly, a stroke is a 2-for-1 combo. There are genetic components of it, but environmental things come into play as well. Things like smoking, obesity, hypertension, diabetes mellitus, or elevated cholesterol. So why are we called the stroke belt? Okay, it's the 5th leading cause of death in the United States. Women have higher incidence than men, and they think likely because women live longer. But why are we called the stroke belt? Because in this area that's in red here on the map, the income, the education, the dietary habits, and access to health care are all limited. And sometimes when we talk about access to health care, it means that you just don't have anything close by. Okay, so when we talk about a stroke, ABCS is what we're going to talk about when we think about health promotion and maintenance. So A stands for aspirin. We're going to use that when it's appropriate. B, blood pressure control. C, cholesterol management. And S, smoking cessation. Okay, so how do we recognize the cues? One of the things I wanted to be sure and say is that if you suspect somebody is having a stroke, you need to make sure and rule out hypoglycemia and hypoxia, because both of these things can mimic neuro problems. If they have a sudden severe headache, nausea and vomiting, photophobia, cranial nerve deficits, a stiff neck, and a change of mental status, this is usually a subarachnoid hemorrhage. Okay? The National Institute of Health Stroke Scale is then done. Signs and symptoms of stroke are sudden confusion, trouble speaking or understanding, sudden numbness or weakness of the face, arm, or leg, sudden trouble seeing in one or both eyes, sudden dizziness, trouble walking, loss of balance, sudden severe headache with no known cause. When we do critical care, our plans are to take you through a mock stroke workup, exactly what you would do in the emergency room. And emotional lability is also a psychosocial assessment for a stroke. Let's talk about right-sided versus left-sided CVAs. Cerebrovascular accidents, a stroke. Okay, right and left. So a right-sided CVA, remember, is going to affect the left side of the body. So don't be confused and try to name a stroke by which side of the body is affected. It's which side of the brain is causing the problem. So if there's a stroke on the right side of the brain, you're going to have paralyzed left side hemiplegia, spatial perceptual deficits. Okay? They tend to minimize problems. What problem? We don't have a problem. Really short attention span. They a lot of times will have visual field deficits, impaired judgment. They're really impulsive. Okay? And impaired time concepts. So let's move on to left CVA. Of course, if the left side is affected, they're going to have right-sided paralysis. This is going to affect their speech and language. They'll often have slow performance, visual field deficits. They can be aware of their deficits too, and often this will cause depression and anxiety. Impaired comprehension. So they're no longer able to comprehend as they once were. So in a stroke, your H&H may be elevated. This will be a body's response to lack of O2 in an area. You need a CT scan for perfusion and maybe a CT angiography, maybe even an MRA or an MRI. Okay? We talked about making sure that it's not a glucose problem. Why would we check a hemoglobin A1C? Because having diabetes can increase your risk for stroke. Okay? PT-INR and APTT, we're going to check these to make sure that the patient has not had or been given anything that's causing them to have a hemorrhagic stroke. Okay? Ultrasounds can also be done, but most of the time it's an MRA or a CT. Okay. So, what cues do we need to analyze? They're definitely going to be showing signs and symptoms of increased intracranial pressure, So what do we see when we have increased intracranial pressure? They may have a severe headache, a decrease in LOC, irritability, okay? Their pupils may be slow or unreactive. Those are all signs of an increased intracranial pressure. All right, with a stroke, you're going to look for decreased mobility and any kind of possible assistance they may need with their ADLs due to their neuromuscular impaired cognition. Aphasia and dysarthria can be due to a decreased circulation to the brain as well, and the facial muscles, okay? Sensory perception deficits are due to altered neurologic reception and transmission. So they're just not getting blood where it needs to go, and things are not processing like they should be in the brain. Okay, so planning and implementation, they may go home. They may need STOT or PT at home or wherever they are, okay? For family education, we always want to use the teach back method, where you teach them something and have them teach back to you, and that way you can evaluate their understanding. Someone needs to be doing a follow-up phone call in 72 hours. They need grab bars installed near their bathtub and toilet. They may even need an elevated toilet seat, okay? Anti-skid pads in the bathtub. Assisted devices, they may need to be trained with those assisted devices before they leave the hospital. They definitely are going to need to be educated on lifestyle changes, drug therapy, ambulation and transfer skills. Also communication skills if they're having difficulty with that. Safety, nutritional management, activity levels. We're going to teach our TIA patients and our stroke patients the FAST mnemonic. F for facial drooping, A for arm weakness, S for speech or language difficulties, and the last one is T, time to call 911. Okay. And there's the FAST mnemonic again there. Home care management may definitely be necessary depending on how bad the stroke is. And what kind of outcomes are we wanting for our patient? What kind of goals are we going to have for them? We want to make sure that they have adequate cerebral perfusion to avoid any kind of long-term disability. So whatever's causing the blockage, if it's a hemorrhage or a clot, we need to try to eradicate those as quickly as we can and get blood flowing back to that part of the brain. We want to make sure that they are maintaining their blood pressure and blood glucose within a safe prescribed range to do no more damage to the vessels in the brain. We need to make sure that they can perform their self-care and mobility activities independently or with an assistive device. Okay. We need to make sure that they're learning to adapt to sensory perception changes if those are present, so that they're not at risk for harming themselves. We need to make sure they have a way to communicate effectively, and that they have adequate nutrition and avoid aspiration if swallowing is part of their problem. All right, traumatic brain injury. This is damage to the brain from an external mechanical force. It's not really caused by neurodegenerative or congenital conditions. Okay? This is shaking the brain in the cranial cavity. Okay? And it can be caused, traumatic brain injury can be caused by many different things. Acceleration and deceleration injuries can cause it. Shaken baby syndrome, where they're shaking the baby so much that the brain hits the front and the back and the front and the back of the cranial cavity. Okay. Primary brain injury just means that it happens at the time of the injury. Okay. It can be really focused one spot, or it can be really diffuse all over the brain. Can be opened or closed. So you can have a brain injury where a patient maybe is ejected from a vehicle and hits their head. The brain, for lack of a better word, sloshes against the inside of the cranial cavity, but the cranial cavity is also cracked open. Okay, so that would be an open type injury. And traumatic brain injuries can be mild, moderate, or severe. Okay, the secondary injury are the injuries that occur after that first injury and they actually worsen the outcome. So post-concussion syndrome, hypotension, hypoxia, increased intracranial pressure, hemorrhage, those kinds of things. So sometimes it is that secondary brain injury can be caused by not using evidence-based practice and treating the traumatic brain injury as it should be treated. Okay, an epidural hematoma. Okay, you see how it's epidural, it's extradural, it's outside of the dura, but it compresses and pushes down on the brain. Subdural hematoma is venous bleeding in the space beneath the dura and above the arachnoid. Okay, and what happens is this happens from tearing or bridging of the veins within the cerebral hemisphere. Bleeding with these occurs more slowly than from an epidural hematoma. So these symptoms may not come about as quickly as the other. Okay. Here's an intracranial hematoma, and you'll notice the different spellings of hematoma here. That's usually because it's European. This gives you an idea, though, of where a subdural hematoma and an intracerebral hematoma and an epidural hematoma happen. See over here with the epidural hematoma, see the white lining of the brain? It's outside of that dura. Okay, it's called dura mater, that white lining of the brain. Over here where you have the subdural hematoma, see the dura mater, that white lining? The blood is on the inside of that. Okay, so what can cause a subdural hematoma? A fall, an MVA, just colliding with anything, a stationary or moving object. There are a lot of them, 1.7 million annually in the United States. So how do we keep this from happening? Teach safe driving practices, avoid getting drunk and falling on your noggin, drugs, marijuana, use helmets, especially in our children, well, adults as well, but we can make sure that our children wear helmets. Sometimes you can't do anything else about another adult, but you can make sure that your children wear helmets. Environmental factors, fall prevention strategies for all of our elderly or patients in the hospital that are high risk for falls. Okay. No two are alike. Okay. So you are going to have those signs of increased intracranial pressure. You may have hypotension, hypoxia, hypercarbia. Okay. Pupils are going to be either sluggish or non-reactive, but we have to ABC them, right? Protect that airway. We also want to do spine precautions here, a rigid cervical collar in the field on a long spine board as well, to make sure that it's just a traumatic brain injury and not also involving the spinal cord. Bed rest, no flexion with a pillow or a roll, no thoracic or lumbar flexion. Have to have manual control of that C-spine if the collar is removed. Going to be log rolling these patients. Frequent assessment of that skin under that collar. And they need to have that spine clearance before any changes are made. Okay, so what does that mean? I'm going to x-ray that spine and make sure it's clear, or CT it before we make any change, okay, in their positions or anything else. Auto-regulation, because it's a brain injury, may be impaired, so we need frequent vitals. Watch for the Cushing triad. This is a very late sign of increased intracranial pressure, so you're going to have severe hypertension, a widened pulse pressure, and bradycardia. And this actually often indicates imminent death. Okay, that's Cushing's triad: severe hypertension, widened pulse pressure, and bradycardia. So a Glasgow Coma Scale, if they have a change of 2 points, this is clinically significant. Most important is their level of consciousness, because a decrease is usually the first sign that they're having problems. So you'll have decreased arousal, sleepiness, increased restlessness or combativeness. Those are all signs of increased intracranial pressure, right? The pupils may be pinpoint and non-responsive if there is brainstem dysfunction. They may be asymptomatic or unreactive, so we're going to treat that as a brainstem herniation until it's proved differently. Fixed or blown pupils is a very bad sign. Okay, check the patient's vision if you're able. And really late signs of increased intracranial pressure are going to be severe headaches, nausea, vomiting, projectile vomiting especially, and seizures. Okay. Edema of the optic disc in the eye is always a sign of increased intracranial pressure. Assess for their bilateral motor responses. Are they posturing like in a seizure type activity, or are they flaccid? Look at their ears and nose. Is there any cerebrospinal fluid coming out of there? Well, how do we know if it's cerebrospinal fluid? Put a drip on a piece of paper. Does it have a halo around it? If it has a clear or yellow halo around it, then it could definitely be cerebrospinal fluid. Palpate gently for fractures. Do they look like they have raccoon eyes? Okay. Emotionally, a lot of times they'll be real labile, like they'll be really happy or really sad. CTs, MRIs, and functional MRIs for any changes. And you may also need to do intracranial pressure monitoring. So you definitely have a lot of reasons why this patient could go bad. You have a potential for decreased cerebral tissue perfusion and a potential for decreased cognition, sensory perception, and mobility. Okay, so we're going to definitely admit the patient. Unless it's just a really, really, really mild traumatic brain injury. We're going to watch our ABCs, monitor for ICP, promote fluid and electrolyte balance, and health teaching and emotional support. And we also want to watch that we don't have any secondary brain injury. And the way we're going to do that is do our vital signs Q1 to 2 hours, do our IV fluids per order, watch for dysrhythmias or any ST or T wave changes, document and report any hyper or hypotension and dysrhythmias. Okay, if they start to run a fever, we need to report that too. That's associated with higher morbidity and mortality rates. You can use therapeutic hypothermia to cool the patient to 89.6 to 93.2 degrees Fahrenheit for 24 to 48 hours, and that's believed to help some. When you have to intubate a patient with a traumatic brain injury, you want to hyperventilate them for the first 24 hours only. A decreased CO2 level actually can decrease intracranial pressure. We're going to make sure we prevent hypoxemia. If we do have a lot of brain ischemia, we might want to consider a hyperbaric chamber for high dose O2. Make sure that when you do things like suctioning the patient, if they're intubated, that you make sure you do that 100% O2 before and after to keep any low dips in oxygen level from happening. Sometimes their cough reflexes can increase intracranial pressure. So sometimes we'll give lidocaine nebulized or by the ET tube to suppress that cough reflex. Mannitol is given a lot of times. That's called the Lasix for the brain. That's mannitol. Furosemide may be used as well because it enhances the therapeutic action of mannitol, which reduces that edema and blood volume. And don't forget pain control, okay? The pain can increase with increased intracranial pressure. Home care when they're finished with acute care, of course, self-management, education, and healthcare resources are all really important, okay? So let's look at page 921 for self-management. 921. These are for those people that you send home, right? You need to teach them to watch for headaches. They can have Tylenol every 4 hours as needed. We shouldn't give them any sedatives and tell them to be sure and not take any sleeping pills or drink any alcohol for at least 24 hours. Okay? Don't allow the person to engage in strenuous activity for 48 hours. Teach them to be aware that balance disturbances cause safety concerns, and they should provide for monitored or assisted movement. That means somebody needs to stay with you, okay? If any of those symptoms occur that I'm going to read off here, they need to call 911 immediately. If they have a seizure, if they have severe or worsening headache, a persistent or severe nausea and vomiting, blurred vision, clear drainage from the ear or nose, increasing weakness, slurred speech, progressive sleepiness, or unequal pupil size. Okay, and we need to make sure we're encouraging them to keep their follow-up appointments as well. Okay, so what are our outcomes? What do we want to achieve for these patients? We want them to make sure that they continue to have good cerebral tissue perfusion. If they have any mobility or sensory perception changes, we need to help them to adapt until those go back to normal. We are going to hope that they have minimal alterations in cognition, or they understand how to compensate for cognition changes when it's necessary. So, brain tumors. The pathophysiology of a brain tumor is just a tumor that originates within the central nervous system. These tumors can be benign or they can be cancerous. A secondary tumor is going to be a tumor that results from metastasis. Of course, these are cancerous, but it's and it's pretty common, from cancers that occur in other parts of the body, and it migrates and transfers to the brain as well. So you can have cancerous tumors in the brain that are called benign, some are called malignant, and some are called metastatic. So, of course, the metastatic ones are where they have cancer in another part of the body, and now it is also in the brain. So what are our common signs and symptoms? Just exactly the kinds of things you would think about if you had some kind of pressure on the brain. Headaches, nausea and vomiting, seizures, impaired sensory perception, loss of balance and dizziness, weakness, paralysis, difficulty thinking, speaking, or articulating words, changes in cognition, mentation, and personality. These are all very similar when we think about other neurological problems like stroke or MS. Some of those signs and symptoms are the same as people with brain tumors. So what kind of management can we do? Non-surgical management, that's going to be drug therapy. You can do chemo alone or a combo with radiation and surgery. They've also had some success with direct drug delivery to the tumor. Codeine and acetaminophen for headaches is what you're going to use. Dexamethasone can control cerebral edema. Going to take phenytoin for seizures. May need a PPI for stress ulcers, which are also called Starling ulcers. Okay, a gamma knife surgery. This is where you have a single high dose of ionized radiation, and it focuses a beam into the cancerous tumor without damaging the surrounding tissue. And when they do that, they have to put them in a rigid head frame so that head doesn't move at all. Craniotomy can be done. So pre-op, we want to reassure or teach them what to expect. In the operational procedure, they can do a transnasal approach for minimally invasive, easily located tumors, or they may have to do an open traditional approach, and this is where they have a brain flap that they cut out to expose the brain. And they locate the tumor, take it out or part of it, whatever their plan is, and then the bone flap is replaced. So they can have a drain or an ICP monitor after this and a dressing cap. Post-operatively, they definitely need to monitor for intracranial pressure. They might need to have some cold compresses to the eyes for that periorbital edema and ecchymosis, and irrigate the affected eyes with warm saline to improve comfort. They need to have on a monitor, like a cardiac monitor, anytime that you're messing around with the brain. And you're going to do some really strict I's and O's. 1,500 milliliter fluid restriction. They may elevate the head of bed 30 degrees, but you are going to avoid hip and neck flexion. Maintain that head midline, especially if the brain stem is worked on. Okay, NPO for a while. Check that dressing, Q1 to 2 hours. Do they have a JP drain? If they do, measure it Q8. You expect to see about 30 to 50 milliliters. If there's more than that from the JP drain, you need to notify the doctor. Follow their labs. Hypernatremia can lead to seizures, remember? So watch for large amount of urine output. This would indicate that they have diabetes insipidus from manipulating the brain, and we'll talk about that more when we get to endocrine. They may be on some anti-epileptic drugs, histamine blockers, PPIs, dexamethasone, and antibiotics. Okay. Want to make sure that they follow up and keep their appointments. You can refer them to the American Brain Tumor Association or the National Brain Tumor Foundation of the United States for further information about brain tumors. So the spouse of the client brought to the ED reports that 6 hours ago her husband began having difficulty finding words. The client has since become progressively worse. Upon assessment, you note right hemiparesis and urine incontinence. What is the priority nursing intervention for this client at this time? So first you think, what do I think's happening with this client? Okay? What do I think's happening? So what do we think is happening, and then what do? Provide perineal care, assess for a gag reflex, elevate the head of the bed, or perform a linen and gown change. Okay, so the airway must be protected. So we have to elevate the head of the bed. That prevents swallowing concerns and allows for an open airway. The client should definitely be assessed for a gag reflex. Perineal care should be provided and linens should be changed. But when you're talking about the most important thing to do first is to elevate the head of the bed. An hour later, after a CT scan, the client is diagnosed with a left hemisphere stroke. Which assessment findings does the nurse anticipate? Constant smiling, intellectual impairment, deficits in the right visual field, disorientation to time, place, and person, inability to discriminate words and letters. The answer is B, C, and E. The client experiencing a left hemisphere stroke displays an inability to discriminate words and letters, intellectual impairment, and deficits in the right visual field. Disorientation, constant smiling, and neglect of the left visual field are manifestations of the right hemisphere stroke. Okay? The client is admitted to the acute medical unit after 7 hours. His wife asks if her husband will receive IV fibrinolytic therapy. What's the appropriate nursing response? 30 minutes later, the wife asks for a glass of water because her husband is thirsty. How will the nurse respond? Okay. There are really strict guidelines about fibrinolytic therapy. Ideally, you're going to give that drug 3 hours after the first stroke symptoms. I think they have increased that to 6, but ideally 3. Before the client is giving any kind of liquids, food, or medication, he has to be screened for the ability to swallow. Okay. The client's wife must leave her husband's bedside for 2 hours to run errands. Which nursing action is appropriate to contribute to client safety while she's gone? Apply restraints, maintain the bed in a low position, sit with the client until his wife returns, or place the call light in the client's right hand. So you should not apply restraints until all other methods have been attempted. Sitting with the client for 2 hours is impractical for a nurse. Placing a call light in the client's right hand would not be effective because he has deficits in his right visual field and may have right field neglect. The client needs assistance with feeding but can swallow well. To whom should the nurse delegate this responsibility? A hospital volunteer, assistive personnel, an LPN, or a student nurse doing first client care experience? Feeding the client falls within the scope of practice of an assistant personnel member. Remember, though, that the first time a client is fed, it is considered an assessment, and only RNs can do an assessment. So apparently this person has already been assessed and found to be able to swallow okay. So an assistive personnel can now feed him. A client with a traumatic brain injury has non-reactive and dilated pupils. What finding does the nurse anticipate? Loss of vision, intense headache, projectile vomiting, or brainstem herniation? This is brainstem herniation. Asymmetric or unequal pupils, loss of light reaction, or unilateral or bilateral dilated pupils are treated as a herniation of the brain from increased intracranial pressure until proven differently. Okay, pupils that are fixed or non-reactive and dilated are poor prognostic sign. Okay, these we call blown pupils. The nurse is caring for a client with a head injury. Which finding requires immediate nursing intervention? Increased pupil size, nausea and vomiting, agitation and confusion, or elevated blood pressure? Okay. They've got a head injury. What do we need to do immediately if we have a problem? If we have one of these problems, we need to take care of it immediately. Which one would it be? C. The first sign of increased intracranial pressure is declining or changing level of consciousness. So we would need to assess the client immediately if this symptom is presented. Okay. A client has experienced a stroke in the left cerebral hemisphere. What clinical presentation does the nurse expect? Aphasia, agraphia, decreased proprioception, disoriented to time and place, or difficulty with mouth calculations? A, B, and E. Okay. Left hemisphere stroke, aphasia, alexia or dyslexia, agraphia, and acalculia. If you haven't noticed, you need to know the signs and symptoms and differences between left-sided and right-sided strokes.